We have Dr. Raymond here, who is our program director, and I also have Dr. Wadozie. He's one of the residents as well. Today we're going to be talking about something that is very, very important, and we're talking about diabetes. It's something that is very common, and what we're going to be doing today is talk about it, answer questions that you may have about diabetes, and of course, we are also going to be telling you how we can prevent diabetes, and if you have diabetes, is also how you can manage it, to ensure that you have the best health outcomes possible if you suffer from this condition. So I always like to start out by asking, and please feel free to ask questions and, make this as interactive as possible, is what do we understand by diabetes? So when we say someone has diabetes, what do we say? What do you understand by diabetes? What is it?
That their blood sugar is
high.
It's high.
Your body isn't able to manufacture enough insulin
exactly.
to keep you status quo.
Exactly, and that is exactly the answer I was looking for. It is a balance. It's a combination of those two answers actually, because it has so many things that contribute to it. But the overarching goal is, at the end of the day, the body is not able to control, the blood sugars, right? It's higher than we want it to be. And there are two reasons why that happens. One is, like you rightly said, is that the body is not producing enough insulin to bring down the sugars. Another thing that actually happens is that the body produces insulin, but the body doesn't react to insulin the way it should. So even though it's producing insulin, the insulin is not working at in the body the way it should, and that still causes high blood sugar. So I would first of all discuss some of the risk factors that can cause make you have high blood sugar diabetes. The first one is for people, especially in young age groups, like autoimmune diseases. That's when your body doesn't produce enough insulin, is because the pancreas, which is the organ in the body that releases insulin, becomes destroyed, right? This is usually found that's called type 1 diabetes, and that's usually found in young people. They usually diagnosed maybe in their first, second decade of life. That's when it's diagnosed. But one that is more common and probably more applicable to us here and in our population is, as we grow older, one of the things that usually predisposes to diabetes as well is also when if you have overweight, people are overweight, or lack of exercise, all the physical risk factors like a diet, all these things also contribute to developing diabetes. Okay, so we're going to take it step by step. My colleague here is going to take it up. So there are ways, just before he continues, you probably discuss how we diagnose people with diabetes.
Okay. So I will be talking about how we diagnose people with diabetes. I also want to just chip in a few more things that are risk factors, things that we know that contribute to diabetes as well. So just like my colleague has said, you can just divide those risk factors into two. One is that what we are born with, maybe genetic factors, We know that in the interest of this discussion, the type of diabetes we have is the type 2, the one that happens at old age. So maybe if your family member has diabetes, it's a risk factor. Maybe most people have either a first degree relative, a parent or siblings that have diabetes. That's one risk factor. And it's also known that it's common with people that are of certain descent, like African Americans or Caucasian Americans or Latinos. These are all some kind of group of people that have more incidence or prevalence of diabetes as well. So we all fall in one of those categories. Either you are Caucasian American or Native American or Latin American. These are also genetic factors. Then for other things that are acquired, if you have that predisposition from your genetics, for other things that are acquired are things like things like if you don't exercise, or if you walk in a place that you have to sit at a particular point in time. Interestingly, even this type of diabetes that we are talking about, the type 2, has also been noticed even in young people that are obese. Just because they don't work out, they have a high weight, they also can develop even the type 2 diabetes. So people that don't work out or don't exercise, or people that for one reason or the other have to sit in a place for pretty much length of time, or you gain weight, these are all the risk factors that can make you have diabetes. Or things like other things like people that if for any reason you have like a problem that damages your pancreas, you can also have diabetes as well. Then along with that, things like if you don't eat well, if you don't eat healthy food, things that food that make you gain weight can also make you have diabetes as well. Then apart from that, I will also just want to briefly talk about how do we know that we have diabetes. Oftentimes, diabetes, for the most part, people that have diabetes are actually people that are screened for diabetes. Oftentimes, they might not even have symptoms. The common symptoms you have is when you pee a lot, maybe you pee several times, or when you have an increased thirst for water, or you eat a lot, or for some reason you think that you are losing weight. But oftentimes diabetes even happen before you have those symptoms, and that is why majority of people are noticed from screening. That is why the recommendation is once you are 45 years and you have these risk factors, either you have a family member, or you're a Caucasian American, or you have a high blood pressure, or your lipids are high. The recommendation is you just have to have a screening at least once in every 3 years. And the screening is you go to your primary care doctor, they check your blood sugar, your fasting blood sugar. Ideally, you don't have to eat for 8 hours. Then you go in for a fasting blood sugar. Once you do that and they check your blood sugar and it's a certain number, oftentimes if it's about 126 and above in 2 times, then you can be said that you have diabetes.
Let's say I know it's quite early, but let's see if I like to entertain questions like as we go on. At this point in time, do we have any questions?
I have a comment.
Okay, yes, please.
Well, it seems like sometimes, because I am a big girl, that they just assume I have diabetes, and it's like, why don't you lose weight? Well, I found after having large babies, and it's hard for women to lose that baby weight, and it's not impossible, but for such a long time, when we're working, we don't have time for things. And this senior center is such an amazing place because it has so many things here to help us. And it is. It's gentle yoga, and just starting with something like that has made a difference.
Yes, and like when it comes to like overweight, like excess weight, there's so many social factors, unfortunate the environmental factors. And then the truth is, there's so many factors that go into being overweight. It's not just one single thing. Unfortunately, it seems like, like the society seems to, frown on these issues. But it is such a dynamic topic that, if we want to talk about it, it's going to be a big bucket on its own. But what I would say is, you should, in all fairness, and everybody is, just to make sure you keep on working on yourself gently and, exercise as much as you can and work closely with your physician. Your primary care physician can also help you with whatever options are available to helping you maintain a healthy weight. It is not one target or one approach fits all. And, we don't assume, it's not actually appropriate to assume that anybody has diabetes. It's always when we do tests, it's the test that confirm. There are a lot of people that are overweight that don't have diabetes.
So in South Asians, for example, South Asians do not tend to get very heavy and they have type 2 diabetes. So you will see a very thin person who is like ideal body weight by all our standards, and you will find out that they are on 2 or 3 pills. So it's just, and again, these the stuff that Dr. Olaya just mentioned, there are many factors which play into it. Blaming someone, I think physicians do less and less of that now. Previously, you would see your physician, they would say, you did not lose weight, you have no point in coming to me now. Right? that thing is gone, because we have found out, eventually we realized that just this paternalistic attitude of shaming someone or acting like you are the boss of their life or you care more about them than the patients themselves, this is going away. We go for shared decision making. You make decisions in your life that might be dear to you, and that has nothing to do with anyone else. There are people who would say, if I won't eat meat, I might as well die. So for them, for that patient of mine, I would not recommend them not to eat red meats, because that's their life, that's what they like. So they're never going to listen to me. So shared decision making is the future, and that's what we are pointing towards.
That makes a big difference. Your kind of your mental comfort with things, and
very,
feeling about
very
yourself.
important.
And if you get discouraged, you just give up, and then
That
maybe
is
you
true.
worse than if you would have just
That is true.
keep trying a little at a time, because it isn't going to happen overnight. But
Exactly.
trying to pack away.
As Dr. Remen said, I think the medical community has also come to realization that we need to work with patients, regardless, and take personal sentiments out of it. And I think that we are seeing more and more encouraging results, because this is opening something else, but there's a very strong connection between the gut and the brain. It's called the gut-brain connection. And if like the mental aspect of it is not well taken care of, the gut also responds to it as well. So it's very important that we also take care of the whole patient, like the whole picture, and not just one picture. So keep on keeping on. All right, do you have any other comments, questions? So we all know what diabetes is, and we also know, like Dr. Wadozie said, sometimes we don't see the symptoms of diabetes, but the person is already diabetic, and that's why it's important for us to do some screening to make sure that you don't have diabetes. I guess a lot of times people don't feel very comfortable with fasting overnight, I think, or fasting before the test. I guess that's what a lot of patients complain about sometimes, but we get to do that. And once, the good thing is that we do have medications that handle my diabetes as well. But I guess that's another topic on its own. So let's just talk a little bit now about, we've talked about the risk factors for diabetes. We've talked about, we can talk about some of the symptoms, right?
Okay. Okay, yeah, some of the symptoms, just like I said, if you see yourself having these symptoms or see someone having these symptoms, just come around for a checkup. If you see yourself peeing a lot, or the increase in the number of times you pee, or the volume you pee, you now pee more than usual, or you see yourself having, as you're peeing, you are losing water, so you are getting more thirsty than usual. You take lots of water, and most of them get peed out. And or you see yourself eating a lot, that you feel very hungry, you eat a lot. And these are all some of the symptoms. And just like I said before, these symptoms, oftentimes these symptoms don't really happen. They come in just after you have been diabetes for a while. That's why the most important thing is to be screened. Once you go for your annual health maintenance and you're over 45, this recommendation is that you check your blood sugar to be sure that it's okay. And these symptoms that might just be there, just a sign that you've been diabetic for pretty long length of time, or you see yourself losing weight for any reason. That's also part of the concern. So these are not specific for diabetes. Other things can cause this, but once you have these symptoms, coming together, you just have to, you're advised to come around or call your primary care doctor to be checked out.
Okay. So who can tell us why diabetes is dangerous? Why are we concerned about it? What are the things that diabetes can do to your body?
Too high or too low of a blood sugar can be fatal.
Yes. Too high blood sugar can cause complications. Too low blood sugar is in fact very terrible. Like you said, it can cause complications, and it can actually cause a coma and death. So it's very important that we keep like blood sugar well tolerated. But have you had like friends or family members who had diabetes and you saw some of the complications of diabetes? Does anybody like want to contribute some of the things diabetes can cause to your body that can kill
One
it?
of my friends had both of his legs cut off,
Yes.
all of his fingers, but his thumb.
Yes,
Another one
exactly.
had another leg cut off.
Yes.
But one was with diabetic right from a teenager,
Yes, it was that.
and the other one was a type 2 diabetic.
Yes, yes, exactly.
So it's,
So diabetes can cause, like you rightfully said, both type 1 and type 2 can cause you to amputations, and we can briefly talk about the reason why that happens. Who else has any other contribution? Thank you very much for that.
Can affect your heart, can
Yeah.
affect all your organs really in your body.
Exactly. Yes, it can affect like your brain. It can increase the risk of a stroke. It can affect your heart, increase the risk of a heart attack. It can cause, like you said, like you to lose your legs. It can affect your kidneys. It can basically affect everything, right? Because every part of our body needs the glucose, the sugar, right? But when it's too high, unfortunately, it also causes something else. One thing that is also very common is it affects the eyes, right? So all of a sudden, the person begins to lose their vision. So there are three major things that we as physicians and working with our patients that we like to screen for and look out for when someone is diagnosed as diabetic. One is what we call diabetic retinopathy. Forget the big name. It basically means like how diabetes, one of the ways diabetes affects your eyes. It can also cause cataracts, but we look at the back of the eyes. Has anybody had an eye exam where they put on dilate your eyes, become dilated, and they take a look at your eyes? So that's one of the complications we look out for. Another thing is it affects the kidneys, and it can actually cause kidney disease and renal failure. So we also check the urine, periodically to make sure that there are no signs of kidney damage. Lastly, is also it affects the vessels. We don't really screen for that, but what happens with diabetes is, I don't know if people have told you that your patients that have diabetes, they don't have any sensation in their legs. Sometimes they lose sensation. They don't feel, if they step on something, they don't feel any pain, or they have like wounds, ulcers. That's because they don't have enough blood flow going to the legs sometimes, or they injure themselves without knowing. And unfortunately, this gets infected and then spreads. And the only way sometimes that we can actually save the patients is by, amputation, which is not something anybody's happy doing, especially in this current paradigm where there are enough medications and with good relationship between the patients and the doctors and the healthcare system, because it's not just the doctors, we can have very good healthcare outcomes for our patients. So a lot of times when I have patients that are diagnosed with diabetes, they panic, rightfully so, but I know for sure, we know for sure that, if we work together, you can basically live a almost healthy life with diabetes without any complications. If, there's or minimal complications with good interactions between the patient and the healthcare system. Okay? So do you have any questions this point in time? Comments?
Well, don't you regularly get checked? Shouldn't your eyes be checked anyway, and you could have glaucoma from other reasons?
Yes. So we recommend everybody gets a yearly eye exam. I believe that's a recommendation because there are other things you want to check your eyes for, not just for diabetes. But in diabetics particularly, we check for what we call retinopathy. I don't want to go into all the medical stuff, but it's just like not too many blood vessels are being formed in your eyes. And when that happens, we want to make sure we take care of it as soon as possible. So yes, you're correct. You should get your eye exam for other things, but in diabetics, we want to make sure they're not having any retinopathy. Okay. Any other questions? Comments? Okay. Who here has been affected by? I'm not going to ask you personally, but someone who has had diabetes. Friend, family. So you see, it's almost everybody, right? It's very common. And did they suffer any complications? I know you mentioned about amputations. Anybody suffer any complications from diabetes? Do you know?
Isn't there poor circulation? Isn't that one of the causes for I know another person that has like nephropathy, I guess it's called.
What do you call it?
Neuropathy.
Nephropathy, I guess.
Nephropathy.
Yeah.
Yes,
And
yes.
that where your foot.
Yeah, okay,
Yeah,
yes.
they
That's
have a hard time walking
neuropathy.
because
Yes.
They can't have
Yes.
feeling because of the
They don't
circulation.
feel anything. Yes.
Doesn't it start out though like a prickly, burny feeling? I guess he had first, and then.
Yes,
Okay.
yes. So what we also do when you come to the hospital is we examine the foot and see if the patients have what we call, like you rightly call it, neuropathy. I just don't want to use all the medical terms, like we don't. So it's called neuropathy, where they check and see if you have like loss of sensations. So it's actually a spectrum. Most patients don't just lose their legs like immediately, but it starts with loss of sensation. There's poor blood circulation. They develop ulcers. The unfortunate thing is when the ulcers are developed, sometimes it's painless. They step on pins, or like maybe on a nail, they don't even feel it, and then it keeps growing, it gets infected, and then it's just a spectrum. And unfortunately, sometimes it leads to loss of like limb, and then we have to cut the legs off, or in other circumstances, like patients also lose their eyesight or things like that. So we really need to stay on top of like whenever patients have diabetes to prevent like these complications.
Could some other conditions just for an example, my parents, neither one is diabetic. There isn't a big family history of that, but
Good.
he did have rheumatoid arthritis,
Mm-hmm.
and he unfortunately died when he was 85. But he had so much medication for that rheumatoid arthritis that he developed a poor circulation that did end up having an amputation.
Okay.
But
I mean, it's difficult for me to comment on that because I don't know the exact specifics. But what I can say is definitely there are some times when if you have they're called comorbidities. The more of like different things going on, it's possible that you definitely have worse outcomes. Rheumatoid arthritis itself is an inflammatory state. Like there's constant inflammation. Diabetes also leads to inflammation. Like if all of this like work together, then it's possible that you have like worse outcomes.
And it wasn't until like when he was actually 85 that it got to that point. But he had struggled for decades with the inflammation and medication for it. And
I'm really sorry to hear that.
thank you. I don't know what could have been done different.
Yeah. Okay, so let's move on and talk a little bit about like the management.
Okay, and how is diabetes managed? We call it management because we refrain from calling it treatment because treatment gives the impression that there's a drug you take, but we call it management because it's a function of a number of factors that end up getting it. So it's actually a component of a lot of things, and the patient or the person that has diabetes is like the center of the whole team. It's a team. The treatment team is made up of the patient, just like Dr. Lyle said. It has to be a shared decision making with the patient, yourself, then your primary care doctor. Then it can also constitute the dietitian who's going to be responsible for the diet. It might also be at some point you can also involve the doctors with special interest in managing diabetes. They are called endocrinologists. Then at some point you also involve some other people like social workers or psychologists. So the first step in the treatment is the non-drug therapy. We try as much as possible. Once you have the diagnosis of diabetes, you try to do the non-drug therapy, depending on how high your blood sugar is. And what that means is, number one, the lifestyle modifications. I mean, it's not just the lifestyle modification that we talk, but this is like goal-directed and comprehensive therapeutic lifestyle modifications. That means you work together with your primary care doctor to set up a goal, a diet goal, and an exercise goal, and lifestyle changes goal as well. So the first component is the diet goal. You come up with a specific diet that helps reduce your blood sugar. And if at the same time your weight is higher than normal, then the goal will also be to reduce your weight as well. Because oftentimes, if you reduce your weight, it can even make you take less of the medications and less of insulin if you take any one. So you set up a goal with your primary care doctor and your diet goal, and the idea is to reduce calories as much as possible. If you're doing like 3,000 calories a day, you can set up a goal of making it 2,000 calories a day. That will mean restructuring your diets, taking more of fruits, more of vegetables, cereals, nuts. But actually, it's a dietitian that will really come up with a good plan, workable plan that can make your diet, therapeutic as possible. So that is the first component, and that requires some level of, dedication. If everything is discussed and you said, heck no, I'm not going to do anything, it's not going to work. It's not going to work. So that means you are actually in charge of whatever. So the whole team is to guide you to make an informed decision of what to do. So that being said, with the diet, you are targeting how much weight you will lose in 1 month. Ideally, we try that for 6 months and try to lose at least 5% of your body weight. Let's say you are 100 pounds, you try it in 6 months to get down to like 95 pounds so that, you have a way to check yourself. We divide our weight loss in every month, you get a weighing scale, get things to check your weight and how to structure your diet, how to change your grocery shopping and all of that. That's the first component. The second thing is exercise as well. Exercise now it's also goal directed. Oftentimes we do exercises. Maybe when you feel like doing exercises, once in a while you go out. I mean, oftentimes those are not as effective as when it's regimented. And the plan is we oftentimes advise to do at least 5 times a week or 30 minutes at each instance, or in fact we can just say do at least 150 minutes of exercise every week, and we mean aerobic exercises that will make you not to overtly exert yourself but to moderately exert and make you sweat. Things like cycling, brisk walking, just anything that will make you increase your heart rate to be above normal as much as you can tolerate, or swimming or cycling, anything that could make you work out at least 150 minutes in a week. You can, based on your schedule now, divide it. Okay, I just want to do 3 times a week, maybe Mondays, Wednesdays, Fridays, maybe 50 minutes each session. That still gets up to 150 minutes a week.
Can I ask her this? Okay, you want to say something?
Okay.
Go ahead.
Did you say 150 minutes a week?
Yeah, a week,
Okay.
at least, minimum.
Can I ask, just hearing, because we as medical professionals, we know all the right things. We know, hey, eat healthy, exercise, we know it. But I want to ask, what are the barriers for you and, like in your population to actually achieving these goals in terms of like healthy eating and weight loss and exercise? Are there things that, like prevent you specifically, or what are the challenges you face when you're told these things? Like, we just want to hear from you. I know the weather probably contributes to it, but
Yeah.
if there's something
Good
else.
now, so. And I think that once they open this place up to the kind of exercise room and the yoga that we have, and
Okay.
I mean, the group that we had was the fastest growing, right, Jackie, of this yoga, and we just support each other. It's just a social
Good.
thing, and it's,
Yeah.
3 times a week. We went from 2 times a week to 3 times a week.
Great.
And so that really helps, but you have to keep going. And encourage others.
Yeah.
I think sometimes people get a little isolated,
Yeah.
especially if it's, snowed in.
Yeah.
So how about diet question? Someone wants to get a healthy, has it been the case that you wanted to get something healthy, but you ended up eating less healthier food because of limitations?
Oh, why? I mean, you can just share the details with us, like, if you don't mind. I think that, for example, if you ask me why sometimes I really want to eat healthy, I wake up in the morning, I'm like, today I'm going to eat vegetables. But the refined, high-calorie diet foods are just so much more accessible than the healthy foods. And that's why if you're at the store, you see the bag of chips, it's right there. You just go, oh, I'm so hungry. Like, why wait before you get something healthy? Let me just, crunch on this bag of chips. So I mean, that's for me. I think that the unhealthy foods are just so much more accessible. I don't know what your own thoughts are.
They're expensive as well.
I was gonna say
Foods
price-wise
are more
too.
expensive. And they're readily available. There is a temptation. If you left the aisle, by the time you're at cash counter, you might want to grab something. And you keep on fighting with yourself. No, I deserve this. No, I do not deserve this. And you end up picking something. I think cooking is also a difficult process compared to processed food, which is packed. If you are gonna try to make something from the beginning to the end, may require some. But someone mentioned about taste. I'll tell you that if you are used to eating chocolates and candies, you will not. The fruit is gonna rot in your house because it will never taste same. If you will, because the amount of sugar in those that thing is so much that the fruit is just your brain perceives as a very bland thing. But if you decrease your level gradually, diabetes or no diabetes, if you eat healthy, and healthy recipes are almost the same, eat more do not eat refined grains, avoid eating sugars, and then try to eat fruits and vegetables. They are gonna start tasting better with the passage of time. So you can supplement them with your other usual diet that you eat.
And you're eating fruits, you can start with bananas and watermelons and slowly go down the less sugary. Don't start with chocolates and then jump all the way to carrots, that might be a bit hard. So you can start, walking your way down, eating more. We do understand, more and more, the more I get to work, and I continue my training, I keep understanding more. And even as a person, it's never a day's job when you're dealing with, healthy eating and also with the exercise and also with, weight loss. The reason why we are asking these questions is we also want to work, at the level of the internal medicine residency program, understand what the elders and our seniors in the communities are going through and what we can also do on our own end to actually help overcome these barriers. So if there are specific barriers that you're also going through, specifically that you want to share with us, we would definitely appreciate it. That's so, we can also, improve the quality of the care that we are providing to you.
And I think this is a very good rendezvous for you. You guys can ask for healthier food even delivered here for you guys to pick up from. I'm just giving ideas from farmers market. In summer months, you can have good food delivered to you. Rather than putting candy bars here or other stuff, you can also munch on some vegetables. You can do it as a group activity, work together and or commit to taking meals from here. It's all about group activity and improving access to foods. But again, commitment to eating healthy is not a punishment for yourself at all. That's I'll tell you that. Someone who has never smoked, at the time when they are dying, did they ever ask, bring me a cigarette so I can smoke because I did quit and I want to get that joy? They never do, because we were never born with instinct to smoke. In similar way, we were always born with instinct to eat what is available to us naturally, especially fruits and vegetables. If they are never your enemies, if you are not developing taste with them, there is something wrong and there must be a solution to that. And one of the biggest solutions is accepting and indulging in eating them rather than avoiding them, trying to make them tastier, trying to see how you can try different recipes that are gonna be helpful in making them palatable to you, and trying to get used to them as well with the passage of time.
Okay. All right. Questions, comments?
Well, one thing about exercise is the older you get, the harder it is. Because some people can't even walk without a cane or something, or a walker or something like that. It's kind of hard to walk too much.
Okay.
And
Things hurt.
yeah, and things hurt, like backs and legs and hips and knees and and you're not going to walk if it really kills your knee or your back or your whatever.
So I have a 5-year-old kid.
Oh, they,
So
they're just.
one day we ran, and of course, like, I made him run ahead of me, and then he looked back and he said, "Daddy, you're so slow." And I said, "Why do you think I'm so slow?" He said, "Because you're old." And I'm like, wow, okay. And that this, what you describe is very, very, like, it's well registered. We understand that. Let me give an example of where we usually encounter this. This is in patients that have osteoarthritis. And one of the reasons, is because obesity can contribute to osteoarthritis, especially of the knees. And for them to get a knee replacement, they have to be below a certain weight. So the orthopedic surgeon says, hey, you have to lose weight to get a knee replacement. And the way to lose weight is to exercise, to lose weight, to get your knee replacement. So it's like an endless cycle. And unfortunately, that is the truth. We do agree. But what we can actually do is try to modify exercises to the ones that hurt the least. So when sometimes patients tell me, hey, do I have to run and jog? No, you don't have to run and jog it can be in your house. It can be you just moving your arms, like slow, like exercises. It can be, stretches. It doesn't have to, you can find something that is least, we do acknowledge that. And if, depending on if you take like some pain medications as well, you can take something that controls the pain and it makes your exercise more tolerable. I don't know if Dr. Eman
I have tons to say on this topic. This is a topic of my interest, but I would limit myself in the interest of time. I would say that regardless of we have our limitations. We have some of us are unable to walk at all. Some people are able to walk. Some people are. So it's like, there are limitations and those are well understood. And sometimes you can try to see what is suggested by Dr. Olaya to overcome those limitations, but it's easier said than done, and sometimes it's so difficult to do that. But try to get one message out of it. As much as you can, move and walk and stay up. Don't sit down. You lose muscles when you sit down for a long time. You get out of condition, and the more you do exercise, the merrier. The more, the better. There are studies which show that one thing, regardless, people had diabetes, they had high blood pressure. One of them had end-stage kidney disease even. But this study showed that as we move past 70, the most active are the ones that live longest by huge margin. So that's the bottom line. If we cannot fight things all our lives, right? We have limits on how much we don't know how much we are gonna live in this world. But again, the bottom line is that the more, the merrier. The more fit you are, the more you are able to run and jog, the better. If you have problems, think about, as he said, modifying exercises, swimming maybe. If you have bad knees, swimming is a good exercise. It's going to be more gentle on your knees. So try to find the workout that best suits you. Try to visit place. Try to go to a mall and just do walking. We don't have malls anymore, but like a place where I was just watching our mall yesterday, and I used to come here with my kids, and it was all full of people. And look at the evolution now. Like everybody, now that we are ordering from Amazon and ordering online, maybe we need to walk around and do some more activity to compensate for every time we do that shopping, because we lost all those steps. And keeping the step counters of, like, there are very cheap step counters to very fancy ones, but keeping them would also help. So exercise with diabetes, with your life in general, with fighting disease, fighting flu, the fitter you are, fighting coronavirus, the more healthier you are, the better you are going to be able to cope with disease.
Yeah, sure.
Get away from the screens and outside.
Yeah.
And another thing is, like with weight loss, you kind of want it to be, you want to lose, 20 pounds in 2 days. But, I find that if you just keep packing away, and it's hard not to get discouraged sometimes because you think, man, it's been a week already.
Yeah, I know.
No. I think those goals
Yeah.
should be kept by months to years.
Yeah.
And Dr. Vidozzi, I know him by his first name. Most of the time, that's what I use. So Dr. Vidozzi is, as he mentioned, he had a very nice talk with residents on obesity and how do we lose weight. Losing weight is a very difficult thing to do, and sustaining a weight that you lose is even more difficult to do. So I think it's a whole new topic, but I would say never be discouraged, because there are benefits of exercise beyond losing weight. You keep the same weight you are exercising, you are doing something better. And it's not only about living longer, it's about your day, it's about the level of stress that you have, it's about depression, feelings of those thoughts about your anxiety or all those. So to the point that it gives you sort of similar sensation that you get a very minor part of that, like as if you have taken a narcotic or a drug. People who exercise on a regular basis, they get the joy out of it, they get the kick out of it, and that's how it helps. So again, losing weight is a bit complex topic. Dr. Vidozzi would agree, but again, as much as you can do in terms of exercise, that's going to be contributing to your to everything in your life.
I just want to add, in order to be realistic, like about if you set a very high goal that is not achievable, you get discouraged. But the truth is that if you just by cutting down on your calorie and trying to exercise 150 minutes a week, you can lose at least a goal of like 1 pound every week. It's quite realistic. If you can just say, if I do this consistently every week, let me try to lose just 1 pound. Before you know it, cumulatively, if you do that, it'll be 6 months, you see how much you've lost. Just by cutting down, get committed to cutting down your calorie, get committed to exercise, and trying as much as possible to exercise. As minimal, as we've said, as little as you can tolerate. Even just brisk walking around. Let me just get up and just walk around the house maybe 10 times today. Maybe tomorrow I can do 15, next tomorrow I can do 20. You just count it. Cumulatively, that helps you get to the goal of losing just 1 pound a week. If you're able to do 1 pound a week, in 6 months you will get to lose at least 5%, and which is what is recommended.
I guess one thing you should always keep at the back of your mind is there are benefits to exercise, like Dr. Rahman said, is even if you're not losing weight, don't forget that you're still getting other benefits from the exercise. Mm-hmm. My professor used to say, fit and fat is always better than thin and lazy. In terms of your so it's always best, even if you're not seeing weight loss, don't feel discouraged. You're getting other things, other benefits from exercising beyond weight loss. It's still good for you in terms of like other health outcomes. So let's just keep that in mind. In the interest of time, we're just going to talk a little bit about like how, like working with your doctor. I don't want to go into the medications. We have like a host of them, and that's like a big thing. But the thing is, if you're taking like insulin or you're taking oral hypoglycemic drugs, medications for hypoglycemia is a very big threat when it comes to like hypoglycemia means very low blood sugar, right? So one of the most common medications we use is metformin. That really a lot of times doesn't cause like low blood sugar, but if you're taking insulin and some other medications, very low blood sugar is something that we really want to avoid as much as possible. So we always advise that if you're taking these medications, that you always have like a snack bar, something that can easily boost your sugar. That's one of the times when I advise people it's okay to take an orange juice. Once you start having those signs, and it usually comes with a headache, confusions, jitteriness, sweatiness. When those happen, it's very important that you take, something as soon as possible. Either you're taking a snack bar or you're taking like some juice. We should try to make sure that we are working closely with our physicians, to check our blood sugar levels. In fact, like we also have a diabetic clinic that does that, working closely to make sure that your blood sugars are well controlled. There's a very new, relatively new device now that they attach to the skin. I don't know if any of you have seen that. It's also on the, you just scan it and everything is remote now.
Freestyle,
everything is smart now. I bought a bottle of water yesterday and it was smart water, and I'm like, why? I was like, okay, does the cap pop itself, or what? Everything is smart now. But like I said, if there's something that I hope you've been able to get today is that diabetes is a totally manageable condition. It's very complex, but it's manageable with very good support from the healthcare system and also with good relationship with the patient at hand. We can totally defeat diabetes. Okay.
I have one question though.
Sure.
About medications in general. There's been a lot of, practically every single person who's type 2 diabetic is on metformin, and yet now, like on the computer, they're saying metformin isn't good for you, and other medications, and you're like,
So I'll be curious though, who in the computer, where is that information coming from that metformin isn't good for you?
well, I can't remember. I don't even know.
That's possible. All kinds of information is available. So
Yeah.
all your concerns, you should talk to your physicians about it. There are certain people for which metformin is not a good medication, but I would say that the biggest development, unfortunately, I would say, because metformin is around for such a long time. When I was a medical student, we still had metformin, and we still have that. A lot of things have changed over a period of time. Metformin is still considered one of the best first-line medications to tackle diabetes of older age. It's used for diabetes, and it has many other benefits. It just allows people to lose a bit of weight, and there are many experimental benefits that they are looking into for metformin. But again, metformin is here to stay in the market. It's a good medication. If you have any questions about any other medication that we use for diabetes?
Just one more.
Come on, but please go
On the
ahead.
computer,
No.
too. But I think it's Rejulia, but I'm not positive, but it's one of the ones. If they end up putting you on, do they take you off all the other ones, or do they add
Yeah.
that to it, or?
So that's a very good question. There are some medications that we can combine. There are some of them that we can't combine. So unless we know the exact ones, I don't know, like off my head, like I believe like GLP. No, don't let us go into the details. But there are some of them we don't combine. Some of them it's okay to combine. So it just depends on the specifics that we are, the medications that we're dealing with.
Yeah, it also depends on the response you are getting on the medication. For example, once you take like metformin, and we monitor the medication, let's say in 3 months, and you are not controlling your blood sugar well with the metformin or with any other one, your doctor can decide to add on another medication just to get you at goal of a certain range of fasting blood sugar or a certain range of A1C level. So it all depends on how much response we get with one medication.
So I think the bottom line with medications is I would suggest that again it's a person's own decision, but do not try to play around with your medications. If you have low blood sugars, you should talk to your physician rather than deciding about changing dose. There are many patients who feel like this is their diabetes and it has to be handled in a peculiar way. I think the doctors should be completely aware about that peculiar way that the patient wants to handle their diabetes. If you or your loved ones or anyone you know has diabetes and they say they cannot tolerate very low blood sugars or very high blood sugars, I think they should make all decisions about their medications, whether it's insulin or it's pills, by consultation of physician. Diabetes is a serious enough disorder that if you use a lot of insulin or a lot of pills, you can end up becoming dead. And if you do not use enough of those medications, you can be in a lot of trouble with complications, as you have mentioned. Everything which happens commonly, diabetes makes it worse. You are more at risk of, if you look at people who develop pneumonia, if you're diabetic, more risk of having worse infections. You think about circulation problems, more chance. Anybody can develop heart disease, but diabetics tend to develop it earlier, and they tend to develop it much earlier if their blood sugars are not well controlled. Being on dialysis, diabetics are at increases. So what can we humanly do as a possibility to help those conditions and delay all those problems is by trying to make sure we follow with our team and try to make sure we follow the advice of physicians. We want to make sure that if we have any concerns about any medication, we write them down and bring it to our physicians and talk to them about those before deciding about stopping to use them or trying to find an alternative ourselves.
Okay. Thank you, Dewey. I hope you all had a good time today. Thank you so much for sharing. Oh, we have something here. Okay, please go ahead.
I have a question.
Sure.
Artificial sweeteners.
Oh, very
You
good.
know, Splenda used to be the big one, and now they're saying that's not good for you. Stevia is coming in. What if a person does use, what is the best one right now?
So I would, not using anything is the best.
Sure.
And I would say that to you because I was using Splenda at one time. Now I stopped even using Diet Coke. I just use because again the question is this: these things are around for sugar. Sugar as a chemical is around for like decades, right?
Thousands of years.
But artificial sweeteners, how human life acts on them from birth till they die, with generations, how it affects us. We have a lot of unanswered things about that. So I would say that for diabetics, they should come in consultation with their physicians. If they are, rather than if they are eating sugars, refined sugars, maybe they are better off using artificial sweeteners. If they just say, I have to, I'm unable to, or I'm going to use sugars no matter what, then artificial ones may be better. For anyone who is not a diabetic, I think I would just
Probably
yeah.
best to take it off.
You want to add something?
No, I totally agree. At the end of the day, we just have to do what we think is best for ourselves. Sometimes, this is good. Tomorrow they say it's bad. Too much information. At the end of the day, sometimes it's just best to.
Our endocrinologist, who is a specialist in diabetes, he does not have diabetes, but I see him drinking Diet Coke all the time. Personal choices, right?
Yeah. My rule of thumb, and this is me, this is what I do, is if I drop something out and it cannot rot in the next 1 to 2 days, it probably should not be eaten. I know that's maybe an extreme, but if it doesn't get spoiled, if you can throw it out and you can still come back, like those nice cakes, with fondant, and you put it there, 3 days later it still looks exactly the same, which means bacteria cannot eat it. But I mean, I'm just throwing that joke. Thank you all so much for coming. We appreciate your time.